Hi there, my name is Sevag Demirjian. Welcome to kidneyguide.org. Today we'll talk about furosemide, its mechanism and site of action in the kidney. Enjoy. To understand how diuretics work, it is worthwhile to review the basic structure of the kidney, namely the nephron. It's the functional unit of the kidney and is composed of the glomerulus. Then you have the proximal tubule, loop of Henle, distal convoluted tubule, and the collecting duct. Importantly, the ascending loop of Henle is water impermeable, whereas the more distal parts of the nephron are water permeable in the presence of antidiuretic hormone. As plasma is filtered through the glomerulus, 2/3 of the water is reabsorbed in the proximal tubule, another 20 or 25% is absorbed in the descending loop of Henle, and the rest is absorbed in the distal parts which are sensitive to ADH. Sodium reabsorption more or less follows the same path with some minor differences. In the proximal tubule, 2/3 of it is reabsorbed, whereas in the loop, mostly it happens in the ascending loop of Henle and then in the distal convoluted tubule. Loop diuretics are the most potent diuretics, despite the fact that 2/3 of sodium and chloride and water reabsorption happens in the proximal tubule. And that's because of downstream compensatory reabsorption. Furosemide, of course, is highly protein-bound, and not much is filtered through the glomeruli. In the proximal tubular cells, furosemide is transported through the tubular lumen, like many other protein-bound compounds. The cytoplasm of the epithelial cells are densely packed with mitochondria, which provide the massive energy needed to reabsorb 2/3 of the sodium chloride in the filtrate. As everywhere else, there is a gradient of higher concentration of sodium maintained extracellularly and a higher level of potassium intracellularly. This is, of course, achieved by the sodium-potassium ATPase pump, an active process which uses energy from ATP, exports 3 sodium ions for 2 potassium ions, with a net export of a single positive charge per pump cycle. The process of transporting furosemide to inside the cell follows a tertiary mechanism with an intermediate step that uses alpha-ketoglutarate. Alpha-ketoglutarate is part of the citric acid cycle that takes place in your mitochondria. It's a metabolite of glutamine, and it exists in high concentrations in the cytoplasm. An electrochemical potential is generated by the transport of alpha-ketoglutarate against sodium. And this potential, in turn, will facilitate the transport of furosemide to inside the cell in a tertiary mechanism. The organic anion transporter is a multi-specific antiporter which is implicated in the transport of many drugs, toxins, and nutrients. Subsequently, furosemide is transported to the luminal side and excreted to the lumen down its concentration gradient. Once it makes it to the tubular lumen, then furosemide swims to its action site in the ascending loop of Henle. Similar to the epithelial cells in the proximal tubule, here in the ascending loop of Henle, the cells are packed with mitochondria due to the ATPase action needed for the establishment and maintenance of the interstitial gradient. On the apical membrane, we have the sodium-potassium chloride symporter. Most of the potassium that comes into the cell through the symporter is recycled back to the lumen through the ROMK potassium channels in the apical membrane. The exit of potassium back to the lumen will ensure the continued flux of sodium chloride from the symporter to inside the cell, and from there, sodium is excreted to the blood through the ATPase, whereas chloride goes through chloride channels which exist on the basolateral membrane. Furosemide, like other loop diuretics, acts by inhibiting the luminal sodium-potassium chloride symporter, and it does that by competing for the chloride binding site. By doing so, sodium chloride reabsorption is interrupted in the ascending loop of Henle. Hope you enjoyed the presentation.